Good evening, everyone. Thank you so much for coming to WFDD's community conversation tonight, especially on this cold and windy night. We really appreciate you joining us. We're excited to have you here. I'm Molly Davis with WFDD, and we thank you all for being here. And I am going to introduce to you now WFDD's General Manager, Denise Franklin.
Good evening, everybody. It's so good to see you. You know, this is really weird for us. We usually just see a microphone and you hear us. So what a pleasure this is. My name is Denise Franklin, and we are so proud to welcome you to WFDD's Community Conversation on the Affordable Care Act, or by its formal name, the Patient Protection and Affordable Care Act. We are so proud to serve everybody in 32 counties, and we are licensed to Winston-Salem, Greensboro, and High Point. So if you listen to us on 88.5 WFDD, I thank you. Thank you so very much. You know, if you go on and look on our About page or go on our website, you will find out that WFDD is committed to being more than your public radio station. We want to be that glue in the community. Remember when everybody used to talk to each other as opposed to text and email, and you could kind of find out what other people were thinking? And so now it's kind of gone. Plus, we've moved away from our relatives, and we don't necessarily live next to each other. So these community conversations give you an opportunity to talk to people who once upon a time you would have run into, you know, just down the street or at the store. So we're trying to play a role in the community that we play on the air. And additionally, when we have these community conversations, you got to be civil. You gotta be in the community where public radio represents best on the air. You cannot yell or scream at anybody tonight, okay? Not allowed. So these community conversations and events like them, we've been doing them for a while, and we're doing it again tonight with this Affordable Care Act conversation. So every time we do this, we do a series of reports on our air, put them on our website, to try and give people some context on what the issue is leading up to the conversation. So what we're going to do right now is give you a multimedia presentation on what has been on WFDD's air for the last 3 days about this particular act. Take a look.
The U.S. Census calculates about 49.9 million Americans are uninsured. So the current affordable health care law is rolling out to give all Americans access to affordable health insurance regardless of medical conditions or income. But not so fast. The law is now being challenged in court. Governors in 26 states claim one aspect of the law, the individual mandate, is not constitutional. This measure takes effect in 2014. It requires all U.S. taxpayers to purchase health insurance from a health exchange system. People would buy benefit packages online, in an agent's office, or over the phone. Now the U.S. Supreme Court justices say they'll decide whether or not the individual mandate is constitutional. Next month, they'll hear arguments on this and 3 other provisions. But according to Dr. Eric Ford, the individual mandate is the cornerstone of the healthcare reform law.
That's where a lot of the savings that were projected resided. And if you don't have that in there, then a lot of the expenses that they built in will have to be paid for by the U.S. taxpayer. So it'll mean a net increase in our federal spending, and we either get taxed or get cut somewhere else.
Dr. Ford travels nationally and internationally, advising on how to meet some of the mandates of the new healthcare reform law, especially in the area of creating electronic information exchanges. Health providers will use this system to safely and confidentially share your medical documents. He's also the Forsyth Medical Center Distinguished Professor at the University of North Carolina at Greensboro. Another point of debate is one word in the law's name: affordable. Is it really? Again, Dr. Ford.
The Patient Protection and Affordable Care Act, is it affordable? No, this is not going to be a cheap program by anybody's estimation. You know, the family of 4 today, the median income is about $99,000. The cost of insurance to those people on an annualized basis averages in around $8,000 or $9,000. That means that healthcare is actually consuming more of its earnings than it did a decade ago by quite a large sum, actually.
If you don't have insurance,
You're hurting.
you're pretty much just set
You
out to
don't have
die.
a chance when it comes to being sick.
47-year-old Wesley Howe and his mother, 79-year-old Bess Wilson, are sitting in the lobby of the Winston-Salem Community Care Clinic. On this Thursday afternoon, the waiting room is crowded. Wesley suffers from ruptured discs in his back, making it difficult for him to walk. He's on a waiting list for surgery, but doesn't have health insurance. His mother, Beth, says that's a burden on the entire family. In the corner of the clinic's waiting room, a petite woman wearing a black hat is sitting, tediously rubbing her hands together, hoping that the clinic can fill 2 new prescriptions. 64-year-old Vernetta Brown suffers from diabetes and high blood pressure. She thought when she retired in 2009 she would have health insurance. But earlier this year, all that changed. Her premium increased to $400 a month, more than she can afford. Vernetta fights back tears.
I've gotten 7 prescriptions. I didn't have the money. You know, I came here, they filled 4, and I had to get the other one filled on my own.
Physicians at the Community Care Center on New Walkertown Road provide free health care and dental services to more than 4,000 uninsured residents in Forsyth, Davie, and Stokes counties. They also see more than 20,000 patient visits each year. And Executive Director Jim Robinson says some of the patients they are seeing are ones they have never seen before.
These are people, some of them who have very good educations. We've had people come through with doctorates and masters, just lost their jobs.
No matter what our nation's healthcare reform ends up looking like, Robinson believes free clinics like this one will always be part of the picture.
A Gallup poll released this month shows that at least 45% of Americans get their health insurance through their employers. While most employers would agree that the current system is not perfect, they are united in their discomfort over the uncertainty generated by the change in healthcare provisions.
Will I be required to offer insurance? What kind of plan will I have to offer? Does it make more sense for me to send everybody into the exchange in 2014, or should I continue to offer coverage on my own?
There's so many unknowns right now, and there's so many conversations about repealing this provision or that provision that they're basically doing nothing. They're just trying to make a decision based on what they have to do today.
99 times out of 100, it's in the employer's financial interest to jettison its health plan, pay the penalty, and send its employees to the exchanges.
In the meantime, some in Congress continue to try to chip away at the law, and next March, the United States Supreme Court will review aspects of the Affordable Care Law, including the individual mandate. They'll decide its constitutionality. The bottom line for business owners and their employees is that they will not see any relief from uncertainty for a long time yet.
WFDD's presentation of the very complex Affordable Care Act. Now, as we move to the discussion portion of this conversation, I'd like the sponsors to be recognized. They are deeply involved in the presentation this evening, thanks to Cone Health Foundation, the Greensboro Public Library, and the League of Women Voters of the Piedmont Triad. Would you please give them a round of applause? And so now to our featured speaker for the evening. Beginning our discussion tonight is a respected journalist and filmmaker and contributor to NPR's Morning Edition. He is nationally recognized as a best-selling author on the subject of health care. His documentaries have furthered his exploration of this issue. His life experience, I think, is particularly remarkable as he has majored in classics at Princeton University at that time. He subsequently worked as a naval officer during the Vietnam War. He's a lawyer. He's been a teacher. You take that and you combine it with his journalism and his commitment to various community organizations, and it makes him uniquely qualified to begin our conversation this evening. Please welcome Mr. T.R. Reid.
Hi, everybody. I'm really grateful to our sponsors for bringing me back to the Triad. It's great to be in the Piedmont. I'm kind of surprised to see the leaves are still beautiful, but I'm glad to see that. And it's kind of a whirlwind tour, but I've actually done a lot of the best of Greensboro while I was here. I went down to that inspiring new Civil Rights Museum downtown. It's great. I got my news from the News Record and 88.5. Knocked back a couple of Natty Green lagers, fabulous. And I had Brunswick stew at Stamey's, so what's not to like? The only problem is to earn all that good stuff, I have to stand up here and explain an incredibly important, in fact, radical change in American health policy and do it in 20 minutes, which is virtually impossible. I'm going to talk really fast to try to get this done. This bill, as we've heard, is officially known as the Patient Protection and Affordable Care Act. In Washington, they've already shortened that to PPACA, the PPACA bill, often just called the Affordable Care Act, and many people call it Obamacare. I think you're supposed to say it with a sneer. I don't care. Any of those terms works fine for me. Reform means change. It means change for the better. You don't do a reform unless you got a problem to fix. So I'm going to start off just giving you an overview, really quick overview of the American healthcare system, and you can see what this bill was designed to do. You may have heard that the United States has the finest healthcare in the world. You may have heard that we have the most expensive healthcare system in the world. You may have heard that we have the least efficient and most wasteful healthcare system in the world. And you may have heard that we have the most unfair, most inequitable healthcare system of all the industrialized democracies. All those things are true, as it turns out. If you have money or good insurance and you live in Greensboro, community with really good health care, man, you're going to get the best care in the world in the United States. That's why Arab sheiks fly to the Mayo Clinic when they get sick. You can get the best care here. We pay more for it by far than any other country. As I point out in my book, in every area, going to the doctor, any kind of surgery, prescriptions, the same pill made in the same factory costs 6 cents a pill in Britain and $1.20 a pill in the United States. We're paying for that. In terms of efficiency, our system is so complicated. We have so many different players, it's a crazy quilt system, which results in huge administrative costs. Hospitals have hundreds of people whose only job is not to treat anybody, it's just to do the billing. And therefore, probably 30 to 30% of the money spent on healthcare in America doesn't provide anybody healthcare. It pays for paperwork and paper shuffling and things like that. That's a lot of money in a $2.6 trillion industry. And our system is fundamentally unfair. Some Americans get the finest care in the world, and as we just saw, 49.9 million Americans have no coverage. If they get sick enough to go to the emergency room, they can get treated. If there's a public clinic nearby, they can get treated. But lots of Americans in the richest country in the world just don't get treatment. According to the National Academy of Sciences, 22,000 of our fellow citizens die every year of treatable diseases because they couldn't afford a doctor. In the richest country in the world, that's happening. Our neighbors are dying unnecessarily. There's your problem. And the Affordable Care Act was an attempt to solve all these problems. And the result, look, it's a complicated system. It's an expensive system in many counties, including Guilford County. I think the biggest employer in Guilford County is the Cone Health System. That's true all over the United States. The hospital and the healthcare is the biggest employer. Huge amounts of money, and therefore the reform turned out to be insanely complicated. The critics of this bill say, well, it's hopelessly complicated. On that point, the critics are absolutely right. Look, here's my book. I explained healthcare all around the world in about 100,000 words. The bill is 405,000 words, and I don't know that anybody's ever read them all. So to explain it very quickly, I'm going to put it into I'm going to explain 4 points. It does 4 big things. Well, actually, even that's cheating, because I'm going to tell you 3 big things, and number 4 is the other stuff, is the miscellany. Number 1 is the expansion of coverage. We just saw 50 million Americans don't have health insurance, and that number is going up at a rate of about 5 million a year. The Affordable Care Act, if it works, is designed to provide coverage to 32 million Americans who don't have it today. That's a good thing. That will reduce suffering. It will save lives. It will prevent kids from being orphans because their mom couldn't get treatment. And it happens in 2 ways. 16 million are going to be made eligible for Medicaid, which is the government program for low-income people. They're just going to expand the definition of who's low income. And so more people will get Medicaid, although this Medicaid runs state by state. States are broke at the moment. But if the thing works right, 16 million more people will get coverage through Medicaid, and then 17 million people who don't have insurance today will be shifted, will be able to buy private insurance. And to me, for most of us, this is going to be the biggest change to come out of this bill, because you can now buy insurance. You don't have to necessarily go through your employer. Some people will, many of us will be able to buy it through what's called an insurance exchange. We just saw that word here. What's an insurance exchange? Nobody knows. I just saw the Pew Trust just did a poll of people on the Affordable Care Act on its first birthday. That was in March of this year. Do you know what's in the bill? 19% of Americans said yes to this. Do you know what an insurance exchange is? Most people thought it was a building downtown where you go buy a policy. And get this, 22% of Americans thought it had already been repealed. I mean, nobody knows anything about this bill. An insurance exchange is an online market. It's a place where you go on the net and buy insurance. I give you an example. Last week, my wife and I went to Maine. I wanted to rent a car in Portland, Maine, so I went on Yahoo Travel, rental car in Portland, Maine, and guess what? 9 companies pop up, each of them offering 5 different car models, and they tell you the price. And you pick the one you want and reserve the car. You've done this. This is easy. On January 1st of 2014, tens of millions of Americans can do that for health insurance. You'll go on the internet, and depending on what state you live in, you will be able to choose from either 5, that's the minimum, in some states 25 different health insurance plans. You pick the one that's best for your family, and they have to cover you. They can't turn you down. Now, I think for many Americans, that's going to be a vast improvement over what we have now. It's probably the best thing in the bill, if you ask me. We heard the professor here say, and many critics say, well, gee, once we have the exchange, a lot of small businesses are going to just drop coverage completely and make their employees go to the exchange. If a business owner does that, the business has to pay $2,000 per year per employee, but that's cheaper than providing health insurance. This is suggested as a criticism of the bill. I personally view it as a feature. It's a good thing, because I think the exchange will offer people more choice and maybe better prices. I worked for the Washington Post Company. It's a big, generous employer, Fortune 500 company. I got one plan. The Washington Post bought one insurance plan, and that was it. On the exchange, I live in Colorado. We're going to have at least 8 plans that I can choose for my family. And get this, if you can't afford the premium, the federal government is going to subsidize the premium and make it cheaper for you. And it's a very generous subsidy plan. A family of 4 with an income of $88,000 per year or less will get that subsidy. That means most Americans will get subsidized health insurance and a broader choice. So the exchange, I think, is going to be a good thing. And in those 2 ways, Medicaid and the private exchange, we're going to expand coverage. Here's the downside. Even if the bill works perfectly as planned, it's going to leave 23 million Americans uninsured 9 years from now when it takes full effect. They just never got to. President Obama ran on a promise of universal coverage, but the politics in Washington were so difficult that he compromised that away. So we're still not going to get where all the other rich countries are. Now, one thing you won't find in this exchange and this listing of insurance plans available to you is a public plan, a government-run plan. This was called the public option. Do you remember this debate? You should have a plan. And the argument was, well, if you're going to force somebody to buy a product, at least give them a government option they can choose. And President Obama, when he ran for president, always promised we're going to have a public option. He said it'll keep the big guys honest. It's competition for the private insurers, make them offer good benefits and keep their prices down. That was the argument for the public option. The insurance companies hated this idea. You know, and it's funny because our health insurance companies are run by Harvard and Stanford MBAs. If you run a health insurance company, those guys make $20, $30 million a year. And for some reason, they were afraid to compete against government bureaucrats. So they bitterly fought the public option. And there was a negotiation that went on for months. And in the end, President Obama and the Democrats in Congress dropped the public option. There is no public option in this bill. And in return, the insurers accepted more regulation of their business than they've ever stood for before. And so this is the second big step. The first step I told you was expansion of coverage. Number two is tougher insurance regulations. Basically, the new law outlaws some of the cruelest practices of the American health insurance industry. Look, health insurance is a good thing. It pays bills. It extends lives. It's a good thing for us. But those companies have introduced some practices to avoid paying bills that are really, really harsh. And they've now been outlawed. Now, the most important change is something called guaranteed issue, and that is what I said before. You pick an insurance plan, and now, for the first time, they have to cover you. The insurance companies have always had this system called pre-existing condition, which is to say, if you've ever been sick, or if you're sick now, we won't sell you a policy. Tough. Which means the people who most need health insurance are not allowed to buy it, even if they have the money, even if they want to. That ends. Now everybody will get a policy. You sign up and pay the premium, and they have to cover you. The insurance companies used to have this mechanism called rescission. Rescission is a fancy word for cancel. And this was a practice, I mean, it's a totally reprehensible practice in my view. I'm trying to be nonpartisan here, but I think this is horrible. They would collect your premium month after month. If you had an earache, you know, or if you had poison ivy, they'd pay those bills. But when you got hit by a truck or you got cancer, they'd cancel your plan. You know, as soon as you needed the insurance, they canceled it. To me, this is reprehensible. But they did it. They did it hundreds of thousands of times a year. That's been outlawed in the new law. They can't do it anymore. There's some anecdotal stories saying they're still trying to do it, but I think it's going to end. Third, there are limits now on the administrative costs of the insurance companies. Traditionally, they have, for every dollar they take in, they've spent about 70 or 75 cents on health care, and the other 30 cents was administrative, marketing, paperwork, salaries, bonuses. The salaries in the health insurance business are astronomical. Those guys make more than oil company executives. They make more than the head of Goldman Sachs. And now the amount of money that they can charge off to administrative costs is limited. Now, what do you suppose that limit is? Let me give you a hint. In Germany, they have private insurance companies, and by law, their administrative cost limit is 5.5%. That means they have to spend 94.5 cents of every premium dollar on people's health. France, 5%. Are you with me? So what do you think the limit is in the new law for American health companies? 20%. Yeah, 20%. And they fought to get that. You know, they fought to make it broader. But it's better. It's better than what we have now. It's the first time we've had a limit on administrative costs. To get all this, and particularly to get this promise of guaranteed issue that they'll cover anybody, the insurance companies asked for, and they were absolutely right, for another clause in the bill, and that is everybody has to buy insurance. If you think about this for about 2 seconds, it's totally obvious that those two have to go together. And in every country in the world that has private insurance, those two go together. Everybody has to buy the policy, and they have to cover everybody. The reason they have to go together is pretty obvious. If they have to issue you a policy, you wait until you get a diagnosis of cancer, and then you buy the insurance. That doesn't work. Anybody who's taken Insurance 101 knows you have to have everybody in the pool. You can't wait until you smell smoke in your basement to call up and get a fire insurance policy. It wouldn't work. So those two have to go together, and as we know, 26 attorney generals. Is yours in this group? Is North Carolina Sue? Ah. Ours did in Colorado. I told him he was wrong. Did he listen? No. To stop the mandate to buy insurance. And interestingly, if you watch these Republican debates, the Republican candidates all favor guaranteed issue. They think it's absolutely right that those damn insurance companies should have to cover everybody, but they're all opposed to the individual mandate. In other words, 2 + 2 = 5. I mean, those two things can't go together. Are you with me? You got to have the one to get the other. And unfortunately, if the mandate is thrown out by the Supreme Court, we'll talk about that later, that's a serious blow. It may be the end of the Affordable Care Act because so much depends on that mandate. Here's what they didn't do in insurance regulation. You know, this business where the insurance company has in-network doctors and out-of-network doctors, and you show up in the emergency room and the guy's giving you anesthesia before your surgery, and you're supposed to say, "Are you in my network?" You know, no, seriously, no, you know, and they deny claims on the grounds. No other country has that. In all other countries that have insurance, you choose the doctor, you choose the hospital, you choose the chiropractor, and insurance has to pay. Only in America do we have this kind of in-network, out-of-network. That was not changed by the law. In all the other countries with health insurance, the insurers have to pay every claim. They can't turn down a claim. Now, has anybody in this room ever had a health care claim denied? It was strongly argued during the debate that we should deny them the right to deny claims, unless it's fraud, you know, unless you're billing for your neighbor or something. The insurance companies fought that, and it's not in the bill. They can still deny claims. Here's the big reform. Are you ready? They have to report how many claims they deny each year, but they don't have to tell you which ones or why. And, of course, the Affordable Care Act still lets the insurance companies make a profit on health insurance, and we're the only country in the world that makes that. But anyway, there are tough new regulations on the insurance companies. The third aspect of this bill is paying for it all. It's going to be quite expensive. There are a lot of changes in the bill, and particularly those subsidies for families buying private insurance. And there's a lot of, so there are two ways of looking at this. President Obama and the Democrats in Congress say this bill is going to reduce the deficit because we've paid for everything. And the Republicans say this is a budget-busting health care reform, and it can't possibly pay for itself. And just looking at this in a strictly nonpartisan, as an objective observer, I would say the critics are right in this case. The bill is not going to pay for itself. The official price tag is $938 billion over 10 years. That's how they price things. And sure enough, in the bill, there's $938 billion of new taxes. So if the official price is right, the bill doesn't add a penny to the deficit. In fact, the official congressional estimate shows that it reduces the deficit over 10 years because the taxes will bring in more than it costs. And the taxes are smart. They looked at the people who are going to be big winners under this bill, insurance companies, drug companies, hospital companies, and most of the taxes fall on them. So if you're going to give insurance companies tens of millions of new customers, well, then raise the taxes on them to pay for it. That's all done. That was a smart thing. Another really important change is everybody here who's employed and gets a salary is paying a Medicare tax. You may not see it in your pay stub, but you're paying 2.9% a month Medicare tax to pay for the Medicare program. if you happen to make your money trading securities or on dividends, they don't pay. People who make money in the financial circuit don't pay a Medicare tax. And now, under this bill, they will have to pay a Medicare tax on so-called financial earnings the same way a plumber and a gardener and a gas station attendant has to pay. To me, that's a smart and fair change. And then for rich people, people making over $200,000 a year, they're going to raise that tax from 2.9% to 3.8%. Probably some people in this room will be paying that higher tax. But hey, you're worth it. You know. So if the bill really is $938 billion over 10 years, it's paid for. It's not going to add to the deficit. The fact is, it's pretty clear that the price of this bill is going to come in significantly higher than that. I won't go through all the reasons, but I think most people who've looked at it would agree with me. So they fibbed about the cost, and therefore, even though they have taxes in there to pay for everything, it's really not going to do it. So I gave you three things: expanding coverage, insurance regulation, paying the bills, and I'm out of time now, so I just review. The fourth part of this bill is what I would call other stuff, the miscellany. Are you ready? It completely revamps the student loan program. Does that have anything to do with health care? No, but it's in there. This bill will end the donut hole that is the part of Medicare Part D where people whose prescription drugs are more than $2,500 a year, you won't have to pay out of your pocket anymore. It ends that. Under this bill, McDonald's, Krispy Kreme, Dairy Queen, etc., are going to have to list the calories of every product they sell publicly. That's probably a good thing. There's probably a health benefit in that. Would you not buy that Krispy Kreme donut if you knew? That's the argument. The bill had a government-run long-term care program for older people who have to go into a home for treatment or get treatment at home, can't get out of bed. It had a program for them, but they just axed it. The Health and Human Services Division just axed that because they figured out they'll never be able to pay for it. So that's gone. The bill promises to pay primary care doctors more than they get now. And that's really important because one of the problems in American healthcare is we have lots of fabulous specialists, cardiologists, radiologists, dermatologists, neurologists. They make tons of money. And the people that most of us go to see most of the time are primary care docs, family docs, pediatricians, general internists. They make the least, and we need more of them. There are a lot of things that the primary care doc can do that wouldn't require an expensive specialist or a hospital visit. And you can't blame these kids coming out of medical school with a big debt for going into radiology. They're going to make a lot more. So this bill will now pay primary docs more to lure more young docs in. It's good. This is a good change. And finally, I need to mention the F.A.A.P. Have you heard of the Independent Payment Advisory Board? Nobody's ever heard of it, but it could be the most important thing in the whole bill. This is a board of, I think it's 12 people serving a 15-year term, and they are going to set the prices for medical procedures. They're going to tell Medicare how much to pay for replacing your knee or setting your broken arm or something. And the theory is that they're going to set prices way lower than we have today, and then the private insurers will follow the F.A.A.P. price system. Doctors hate this. Doctors hate the idea that the government's going to set a price for their procedures and probably lower the price. The hospitals, which had more clout than the doctors, fought this very hard, so it won't apply to doctors until 2019. I mean, to hospitals until 2019. But in theory, F.A.A.P. could significantly cut the cost of health care in America if it works. If we got a really feisty, populist, non-medically trained person to run this board, who wanted to take on doctors and hospitals. I mean, everybody wants to cut government spending. This is a way. It might work. It may not work. That's, look, did I mention it was complicated? This is a very complicated bill. Let me just mention it in the end. I just want to go very quickly over some of the critics and some of the supporters. This has been called a government takeover of medicine. You've heard that. It's not. under this bill, almost everybody in America under 65 will still get their care from private doctors, private hospitals, paid for by private insurance. That's still going to be the count. It's not a government takeover of medicine. It's been called a job-killing health reform. Have you seen that bumper sticker? It's very common in Colorado. As a matter of fact, since the bill was passed, our economy has added about 2 million jobs, and a third of them are in healthcare. The industry is gearing up for this bill, so it's not a job killer. It's not going to cut the deficit, as I said. And finally, and I think reprehensibly, the worst part of it is it's not going to cover all Americans. It should. It's not, but that's where we stand. Thank you. The far one.
All right. Thank you very much, Mr. T.R. Reid. You know, that other stuff in point number 4, that's what we call driveway moments in public radio. That was so fascinating. We would have sat in our cars and listened to the other stuff category. Really, really fascinating. And so now we would like for you to meet our other panelists this evening. And as they are assembling, there will be mics that will appear in the aisles. So I hope you've been taking good notes, or if you have your burning questions, we're going to ask you to drive this conversation forward in just a moment. First of all, Dr. Marian Earls is our practitioner on our panel. She is a developmental and behavioral pediatrician. As you can see from your brochure, the nonprofit private practice in Greensboro with which she works serves people who have historically had the least access to health care. She is the immediate past president of the North Carolina chapter of the American Academy of Pediatrics. Please welcome Dr. Marian Earls. Our next panelist is a professor of law and public health at Wake Forest University with appointments in law, business, and the medical schools. He consults regularly with government officials, foundations, and think tanks about healthcare public policy issues. He was recently appointed to one of the federal advisory boards implementing part of the healthcare reform law. He's often quoted in national publications, including the Washington Post and Bloomberg. Please welcome Mr. Mark Hall. And finally, our next guest's career has spanned more than 25 years in areas including public health, community mental health, faith-based nonprofits, and programs for the homeless. He is currently the president and CEO of the North Carolina Community Health Center Association, which represents the interests of North Carolina's health centers to federal, state, and local agencies and officials. Please welcome Mr. Ben Money. Now what I'd like for you to do What I'd like for our panelists to do, our newest panelists, is just talk a little bit about themselves and what they're going to feel comfortable about talking to you, or which questions that they feel comfortable answering, which categories. Let's go with Mark.
Oh, all right, yes. So I like to play tennis. I feel like I'm on a dating game or something. I just
you know,
no, just kidding.
There's one in every crowd.
We know each other. Sorry. I am working hard on the constitutional challenges. I'm writing a brief. One of many people writing briefs to the Supreme Court. My position is in favor of the law for reasons that Mr. Reid explained so exceptionally well. But I'm happy to talk about sort of the ins and outs and pros and cons of the constitutional issues. I'm also involved with the insurance regulation pieces that he did such an excellent job decoding, and that's the perfect term for trying to tease apart what's really important and what's more peripheral. And there is so much built into the law. It is hard, I think, to keep your eye sort of on the prize, and Mr. Reid really helped us do that. To recognize what the law does most centrally is to make sure that we're all forever insurable. We may, from time to time, lose our insurance, go in and out of coverage for various reasons, but we can always get back in because of this law. That's sort of the one central feature that's an absolute, that's a certainty, that will never go away unless the Supreme Court or whatever strikes it down. But that simple fact of being able to keep what, not just keep what you have, but to maintain the ability to get onto insurance at any point in your life, regardless of changes in circumstances, is so key. So understanding how that law brings that about and how these exchanges work, sort of the intricacies of the insurance market is another area that I feel like I can address as well.
All right, very good. All right, Marian.
Sure. So I'm the pediatrician of the group here, and have had a very intense involvement with the American Academy of Pediatrics nationally and with Pediatric Society here in North Carolina. And we are major advocates for children. So I'd be prepared to talk about the bill in terms of what it has to offer for children, what that means for access and getting families covered. We are pleased that it's not only going to be the kids that get more coverage, but also perhaps their parents. I'm also very involved in the North Carolina Medicaid. I'm one of the clinical directors for Community Care of North Carolina, and so would be glad to talk about what this means for Medicaid and our very outstanding Medicaid program here in North Carolina.
All right, very good. Ben.
Okay. I'm here to talk about access to care. I represent the federally qualified health centers. These are organizations that provide primary medical, dental, behavioral health, pharmacy, and what we call enabling services like transportation and interpretation for anyone who walks in the door, regardless of their ability to pay. These organizations are unique because they're actually governed, a majority governed by the patients that actually use the services. And they receive some federal support along with accepting Medicaid, Medicare, and private insurance, as well as assisting individuals that are uninsured through payment plans and through essentially just providing them care at no cost. So what I want to talk about today is just how the Affordable Care Act actually expands access to care through these type of clinical initiatives. And one of the things that we're working on with a number of partners in North Carolina is how we can expand these clinics throughout the state. How more people can actually have access to a primary care, patient-centered medical home. And one of the things, too, that we believe is really important is the fact that when we come into a healthcare environment, we don't just come in as a body with a disconnected head, where dental is taken care of somewhere else, where our behavioral health, our mental health, and our substance abuse needs are treated by someone else. We come in as a whole person. And so that whole person approach is really very important. Regardless of what happens in the Supreme Court, regardless of what happens in the election next year, people are still going to need access to care. People are still going to be unable to afford care without some insurance coverage and without some means of being able to access the system. And so we're pressing forward with an initiative that includes hospitals and health departments and free clinics and rural health centers to try to make this type of access to basic primary care, where most health care is delivered, accessible to all.
All right. Okay, so are you ready? All right, run to the microphones. I'll ask a question to give you all time to get in place, but this is your night. It is time for you to find out all kinds of information that you may not otherwise have access to. So while they're lining up, my question is, Mr. Mark Hall, what's your best prognostication in terms of what's going to happen in March?
That would be the basketball tournament. So,
Carolina.
You got one more time.
Two strikes. The Supreme Court hearings are in March, and we expect a decision by June. So the briefs are due in January. So it'll be exciting spring for us lawyers, and I think it's constitutionally the case of the decade, but for healthcare law, it's the case of the century. It has such monumental stakes, and I do believe that Mr. Reid's right that this will make or break the law. If the court strikes it down, it won't survive. Even though it's one small or one sliver of the law. It's such a fundamental, important thread. The whole thing unravels. So, what do I think will happen? I think there's a good chance the court will uphold it. The lower courts have split, but the split is no longer on ideological lines. We now have several leading conservative judges from the intermediate appellate courts upholding the law, and I think that's an indication that it'll probably be upheld at least by a count of 6-3, perhaps even 7-2.
Okay, all right. If you will, give us your question. If you care to identify yourself, you may, but if you'll do me a favor and tell me who you want to answer your question.
Hi. My question is either, I guess, for Mr. Reid or Mr. Hall or anybody else who happens to have read the whole bill, and I've tried and haven't been able to. The American healthcare system has been based on a model of curative-style care. We have really not talked about prevention. In fact, it's almost a bad word. What's the new bill going to do to encourage preventive medicine, which is often much less costly than cure-style care?
Can I ask you what county you live in if you don't want to identify yourself?
Oh, sorry, I don't mind identifying myself. Cecilia Yanku. I'm a medical sociologist. I'm also a Canadian. And I convert as many of my students as I can.
Interesting answer.
Okay. Well, within the Affordable Care Act, there is a public health trust fund. And the public health trust fund is really designed to implement a broad array of preventive programs. The unfortunate thing, though, is that Congress is starting to defund the Public Health Trust Fund. Also, within the Affordable Care Act is a health center trust fund that would actually expand, as I mentioned earlier, access to community health centers, as well as increase the National Health Service Corps, that program that actually incentivizes medical students, nursing students, students in behavioral health sciences, that when they graduate will serve in an underserved area as a means of being able to repay their loan. One of the challenges is with the budget compromise this past spring, some of the core funding for those programs was taken away, some of the base funding. And so these organizations have had to essentially dip into the trust fund to be able to keep the ongoing operations going. So, while there's a strategy in the courts now to, in a sense, make the law, forgive my lack of legal terms, but, null and void, there's also been this effort in Congress to defund health reform by pulling funding away from some of the core programs and forcing the funds that had been set aside for health reform to be used to in essence, shore up basic operations.
Did that answer your question?
It did in a way, but I'm still interested just in the regular consumer. Will they be able to go and seek out preventive care?
Tom? Okay.
There is a significant amount of emphasis on the concept of patient-centered primary care medical home, which is very prevention-oriented. And particularly in the area of health care for children, the benefit package is for any insurer who's offering a plan in the exchange, they're going to be required to cover all of the preventive services that are described in Bright Futures. If you're familiar with Bright Futures, it's the set of guidelines for preventive care for children. I always remind folks that the set of preventive services for children in Bright Futures starts with paying for prenatal visits for the mom to plan for the infant. So those services are supposed to be covered, as well as oral health and vision for children. So that's huge. If you've read the ACE study, that's where we should be putting our money, is on those kids in terms of prevention. So that is there. And then the emphasis on primary care medical homes. So there was a nod, at least, to prevention.
Okay. Thank you very much.
This law makes it much easier for employers and insurance companies to reward you for being healthy. Or another way to put it is, they can now charge you a higher premium if you're fat or you smoke. And that's been hard to do in the past. It makes sense. It encourages people to go to the gym and stuff, and that's in this bill too.
Okay, let's swing over to this microphone.
Greetings. My name is Charlotte Williams, and I'm a Guilford County resident. My question is for Mr. Reid. The I.P.A.P, forgive me if the acronym is wrong, who comprises this 12-person team, and how are they selected?
I.P.A.P is the Independent Payment Advisory Board. Is it 12, Mark? Do you remember?
Sounds about right.
Yeah. I think the Secretary of Health and Human Services picks it, which means if you look at how things work in America, the American Medical Society will pick some, the hospital people will pick some, patient groups will pick some. It'll be a fairly political choice, but you can't have any outside income. That is, you can't be paid by the drug companies while you're working for I.P.A.P. That's really important, and I think it's a 15-year term, isn't it?
Yeah.
So you've got to really be a person committed to controlling healthcare costs. And there are a lot of candidates. I bet there are a bunch in North Carolina who could do this job. We have 2 or 3 candidates in Colorado who would be fantastic. I thought, personally, I felt the best person to run I.P.A.P would be this woman who's now running for senator in Massachusetts, Elizabeth Warren.
Elizabeth Warren.
If you remember, she took on the banks and the brokerage business in a ferocious way. And we're going to need a ferocious populace to take on these interest groups. There is no I.P.A.P yet. The naming of those people is going to be intensely political. And it may be that they'll just pick some safe, responsible person who won't do anything. But, if somebody tough gets in there who's not, a doctor or married to a doctor or something and wants to crack down, I'm not saying this is good or bad, but it could happen, then we could get really serious control over price. And most countries do this. Most rich countries, the ones that I told you spend half as much as we do on health care, one of the major ways they do it is they really control prices for doctors and hospitals.
All right, you can answer your question? Thank you. Sir.
Thank you. I'm Wesley Root from Greensboro, and fortunately I retired this year with very good, cheap health insurance and very little need for it. Good. Very fortunate. May I say that I would like Mr. Reid to move back to Japan and do regular commentaries on NPR again. Very interesting. When the bill was being debated, I remember hearing a fair bit of discussion that, of course, fee-for-service is the killer for health expenses, and that there was quite a bit of discussion about encouraging, promoting, and somehow implementing more of I believe, the Mayo Clinic model. Mr. Money and Dr. Earls both alluded to this, I think, just a moment ago.
Well, I think already there's movement, particularly in the patient-centered primary care medical home area, where if a practice is certified as patient-centered primary care medical home, that people are going to get paid for their outcomes, for their performance. So are they participating in quality activities? Are their patients healthier? Are they keeping people from being admitted to the hospital? So I think payment is going in that direction, which would move somewhat away from fee-for-service.
Well, is that additional money in addition to fee-for-service?
The models I think will be varied. I don't know where that will go, whether that will be sort of a bundled payment sort of a system. In North Carolina, in Medicaid, there's a combination. There's a fee-for-service and then a per member per month for those folks who are participating in quality activities.
I'm sorry, I'm hogging the mic, but is that the Mayo Clinic model?
Well, I think there's another
payment per person.
There's another component which gets to this idea of accountable care organizations that we're starting to hear a lot about in sort of the business community side of healthcare finance and delivery, where traditionally with fee-for-service, each player sort of gets paid their own little part, and that's why when you go to the hospital, you get one bill from the hospital, one bill from the doctor, all these different bills, versus a more bundled form of payment. So Mr. Reid's book is about treatment of his shoulder. Instead of going to all these different providers and each one charging for different things, you could have one bundled payment for fixing a shoulder problem. But the problem is to bundle a payment that way, you have to have one integrated, coordinated organization that's able to treat the case and accept the money and decide amongst themselves who gets how much of that bundled payment. So this I.P.A.P is not so much just to sort of ratchet down the fee-for-service amounts and say we're going to cut prices by 10% or 20%. It's more to figure out how to do this bundling. What's the logical way in which to say, all right, here's a problem that we can, like cancer. Okay, with a single price for this kind of cancer that covers the full range of it. That has to get divided up between the primary care docs, the specialists, the hospitals, the radiation, all the different pieces. So we need to restructure our delivery systems to have these more coordinated teams of care specialists capable of being responsible not only for the outcomes of care, the quality of care, but for the cost of care in a more collaborative way.
Okay. Next.
Yes, my name is Robert Jolly. I live in Winston-Salem, and I guess one of the questions I have a little bit confused about is it seems like this act is principally addressing health care cost, and when I think of health care, the cost is part of it, but the outcome is much more important. That's sort of a thing. And how does this bill address outcomes? And I'd like a discussion of how our health care system compares to other countries, because I know you alluded to this, Mr. Reid, before, but our outcomes seem to be disjointed, and I do not understand how this bill really addresses the poor performance of our health care system.
Do you all understand the question? What do you mean? Okay, all right.
So you could say, I mean, if you were really to simplify, and that's what us reporters do, that there are three problems with American healthcare: cost, coverage, and quality. The fundamental thrust of the Affordable Care Act is coverage. It's going to get 32 million more people covered. One of the strong criticisms of the bill is it doesn't do enough to control costs. That may not be a fair criticism. F.A.A.P could really control costs. There are a lot of mechanisms in there that theoretically could control costs. And as for quality, I went around the world looking at other people's healthcare systems, and one of the most disturbing things I found is that, this is astonishing to me, but compared to the other rich countries, we're mediocre when it comes to healthcare outcomes. It's disturbing to me, but the Commonwealth Fund in New York, it's a great organization, a bunch of Americans, and they issue these international report cards on healthcare. And always among the 23 richest countries in the world, the United States on most levels of healthcare quality ranks 20th, 21st, 22nd, like that. We're best in the world at recovery rates from breast cancer. We're really good at that. We're second in the world in recovery rates from prostate cancer. If that's your diagnosis, you ought to be in America. Many other problems, diabetes, rheumatoid arthritis, many other common diseases, we rank near the bottom. And here, you want to get the really bad news? Neonatal mortality. This means keeping a baby alive beyond her first birthday. Of the 23 richest countries, we rate last in keeping
Okay,
babies
so why
alive.
do you think that is?
I know why that is.
Well, I think
Look,
I do too.
It's
but
not because we have fabulous doctors. We have the best obstetricians anywhere. You want to have a baby, have it in America. She'll be perfect. No, the problem is the people who don't get care. Do you know this number? Estimates vary, but about 30,000 times a year, right? A woman shows up in an emergency room in the United States, 8 centimeters dilated, ready to give birth, and she's never seen a doctor. 30,000 mothers a year get 0 prenatal care, and those are the million-dollar babies. Those are the babies we put in the NICU, the neonatal intensive care, and we lose them. It's not because people going to the doctor have bad care. That's great. It's the people who don't get care. So in terms of quality, we don't rate that well compared to other rich nations. When you think of all the areas in the world where we're number one, you think keeping babies alive should be something we could do. And the bill has a lot in there on quality. It has it has an innovation center. It has a lot of research money. It has some requirements in the payment scheme that doctors, produce good results. It's stricter on drugs. It's not going to pay for drugs that don't work anymore. Well, we have done that in the past. And so there is stuff in there. Now, is it going to work? Do you know? Can you... Look, we don't know. But there are definitely efforts in that bill to deal with... certainly coverage is number one. But there's definitely quality in that bill. And there are efforts to control costs. in theory, it goes after all of them.
Okay. Let's swing back to this side.
Going back to outcome a little more, I work for a large company that consults with most of the Fortune 500 companies on this business.
Yeah.
And a year ago, after the bill went in, they made a bet that this exchange system was going to fly. And they put in a division that said, we're going to advise all these companies on how to do this. And this year, they became an early advocate of that by putting us into an exchange system, supposedly, in our own benefit enrollment now. So instead of last year with one company and 3 different coverage levels, we now have 4 different coverage levels from 2 companies we can choose from. The bottom line is when you add up the premium and the deductibles, and these are all high deductible plans because that's all we have anymore, the cost for the person is about the same, or you and your family, or you and your spouse. So we are going with the lowest premium we can get because our physician is not in any network, doesn't even deal with insurance companies, won't file for you. We pay that person up front. We go and get the reimbursement from the insurance company ourselves. And it's an extremely low reimbursement because there's no network. And this is an integrative physician, and a lot of the procedures we use aren't even covered in these plans. So I think this is a good program and a good law that's going to help cover people. But for those of us that it really doesn't impact, health insurance does not equal health care. We would rather save the money up front, pay our physician directly, rather than support the medical industrial complex.
Now, how does that impact people who have historically had a problem with accessing the healthcare system, though?
Well, I think the health benefit exchange is really going to help them because what happens is there's going to be levels of plans. There's going to be a gold, a platinum, gold, silver, bronze plan, and then there's going to be this essential benefits package. And that will allow for people to not only purchase a plan that's affordable, but actually have some subsidies associated with that. But I think one of the things that the questioner brought up is very important, and that is each one of us has an individual right to manage our own health care. And we also have a right and a responsibility to manage our own health through, best practices of not smoking and trying to do our best in terms of our eating and that sort of thing. And one of the components that we talked about in that whole concept of the accountable care organization is this whole focus on outcomes and having a payment that's not so much based on the procedure and who provided the procedure, but what was the actual endpoint of that patient's care. And by having that kind of model, you can begin to incorporate health education and nutrition and more wellness initiatives to help people to have the tools and the resources and the skills and the knowledge to be able to put that self-care into practice.
Okay. Sir.
Thank you. My name is Keith Hoyle. I live in Greensboro. If 32 million people will be covered under this bill, that will leave apparently about 18 million who won't be covered. So my question is, who are these people? And if the law is upheld by the Supreme Court, what's the likelihood that they'll be brought into the system at some point?
Mark?
So I'm prepared to answer that because I was part of a study that looked at that question. A large percentage, over a third of the remaining uninsured, will be folks who are eligible for Medicaid and just haven't signed up yet. And I like to think of them as sort of virtually covered. They can be covered at the point of service. We wish they would come in and get signed up with their medical homes and get the preventative care, the prenatal care, but they can be covered immediately. And so there's sort of a sense of virtual coverage. So that's sort of a technical argument. Those who there's another chunk of folks, maybe a quarter of folks who will not purchase insurance because they don't feel they need it and they're willing to pay the tax penalty. And the tax penalties aren't that great for, I think it's something like it starts at about $700 a year and goes up to 2.5% of income, but you never have to pay more than the cheapest plan. And so several million people will opt to be in violation of the law in that way. But there's another significant component, whatever is left from my calculus, that includes folks who are either still have no affordable insurance option because the subsidies still don't bring the cost down low enough. So even though the family of four with $88,000 gets some subsidy, they get a very small subsidy because it's a sliding scale. And the insurance companies still have to charge average community rates, but they can still adjust that by age. So folks who are in the middle income brackets who don't get as large a subsidy, who are above, say, 55 or something like that, who can still be charged more, still may face a premium that's not affordable, and they're not subject to this mandate. But the most important component that's left out uninsured are folks who are undocumented immigrants, or those who have legal immigrants but haven't lived here for at least 5 years. And so this gets to a very divisive sort of social issue. Mr. Reid said, the millions of Americans who won't be covered, and of course we have this sort of social debate about who is entitled to be part of these basic social programs and who aren't. And I think it's going to be the case that once the law takes effect and we see, the dust settles and who's left out and who's included, that we'll have to return to this question of what level of access are folks entitled to who are in the country, who have families, who have jobs, but whose legal status is in question.
Okay. Ma'am.
I'm Mary Nell Smith. I'm from Greensboro. My question is really for you, Denise, because there was something on the...
Back me up.
Well, it was on WFDD while I was driving home tonight, and Mr. Reid spoke to it, but they were talking about if you had more than 50 employees, then you would have to provide insurance, but the fines were so low for that many employers would just... What it said was go to the exchange.
Yeah, dump there.
Right, and the
microphone.
And the speaker on the radio said, and that would be bad. It seems to me that would put more people in the exchange, and that would be good.
Well, you just listened to my speech. That's my argument. We ought to ask, what do you think? Am I right? To me, for me personally, and I worked for a big Fortune 500 company, I would have been better off in the Colorado exchange. I think most people will, but as I say, a lot of people see that as a criticism, that employers are going to dump coverage. I'm with you. I think it's better, but yeah, I heard that on 88.5 too. Okay. No, they're going to dump people into the exchange. I think that people, what do you think? Am I right?
Well, we have all of these intelligent people. This is what's so fascinating about this law, who really can put forth arguments on both sides, and these are folks with a whole lot of credentials. So, Mark, what do you think?
It hasn't happened in Massachusetts. The federal law was modeled after Massachusetts, and the Massachusetts employers have stayed with their coverage, and the penalties there are much lighter than they are under the federal law. So, but that's one state, so we don't know that tells us.
It's a work in progress. Yeah. Okay, sir.
I'm David Olson. I live here in Greensboro. I have a question for the panel about the future of health insurance companies. And I'm particularly interested in Mr. Reid's observation that in other countries there are private health insurance companies who act somewhat differently than ours.
Yeah, as I said, the United States is the only rich democracy that allows health insurance companies to make a profit. And under the Affordable Care Act, they'll still make a profit. In fact, they'll make more profit because they'll have more customers. And these new taxes I mentioned will be subsidizing the premium. The insurance companies are going to be big winners if this bill goes into effect. And that's why they're being taxed heavily to pay for it. They're still going to come out way ahead. They love this bill. They wrote this bill, a lot of it. Not all of it, but they wrote a lot of this bill. And that's why they didn't want the public option, because they want the business. They're going to do fine if this bill takes effect. If we followed the model of other countries, we would require them all to be nonprofit. In other countries, many countries, this is an important point, many countries rely on private insurance. It's not all socialized medicine overseas. Germany has 220 private employers. They're not government, but they're not allowed to make a profit. They still compete with each other, interestingly. I think it would probably be better if the payment scheme for health care were nonprofit. If hospitals, doctors, labs make a profit, that's fine. But I think, personally, I thought the systems worked better in the companies that didn't allow profit in the insurance plan. But that's a big change for Americans, and I don't know that we're going to make it. So my guess is I'd buy stock in insurance companies because I think they're going to do fine out of this bill. That's my judgment. And guess what? Wall Street agrees. You know, they're the strongest stock sector there is.
I'm going to timidly disagree with you, Mr. Reid. All right, yeah. So not to defend the insurance industry, but many of our insurance companies are nonprofit. North Carolina, Blue Cross Blue Shield of North Carolina is nonprofit, and many of the other Blue Cross plans are. The difference is that they're the principal source of coverage. So I think one of the other differences you see in the European systems is the insurance companies are supplemental or residual. There's sort of a basic government, I guess safety net would be one term, or under, I'm trying to think of a non-technical term, underwriting, or there's sort of a basic public plan, and then people often buy insurance supplemental to that. I know the German system is based around insurance types of cooperatives as a principal source of coverage. And the Affordable Care Act does promote this idea of nonprofit insurance. It funds the creation of these new cooperatives under the hope that they can present sort of a different model. But I do think that I wouldn't go quite so far to sort of blame the insurance industry for the bill that we got. I think that we got the bill that this country wanted. I think that this country in general is more worried about government-run insurance than the kind of insurance that we have now. And I do think that the insurance industry was sort of ready to reform itself. I think they were eager to get rid of this sort of picking and choosing and excluding of people. They were. It isn't just more customers. There's a basic principle that Mr. Reid explained, I think, very well, and so it's really a matter of emphasis rather than disagreement, that it's fine to take everybody as long as people aren't deciding to purchase when the house is on fire. And they were quite ready to accept that principle and to get rid of this sort of screening people for health status, because I think they prefer to do business that way. It's not sort of some evil spirit in this of the industry. So we're trying to sort of make the best of the kind of structures we have in place: employer-based insurance, a commercial insurance industry. And sure, there's a lot of sort of push and shove and give and take in terms of the politics, in terms of the interest groups, but it largely fits the structure that has grown up in this country. Right or wrong, that's what we have, and so, America, love or leave it. Sorry.
Okay, Susan, please.
Susan Shoemaker from Greensboro. I have an observation that I don't think I've heard tonight, and if I missed it, I apologize. And that's the comment that kids under age 26 can stay on insurance, on their parents' insurance plans, which I think is a big win, particularly for those of us that have kids that are emerging adults. And I guess a question either for Mark or TR is, if the individual mandate is not upheld, there's a lot of opinion that I've read that says if the law unravels, that they still believe that the cruelest insurance practices, as you aptly talk about with pre-existing conditions and insurance portability, will remain in place and covering kids under 26, because those have been really embraced and endorsed. I'm just interested in your opinion.
Marian, you want to take the first part about that?
Well, Susan's correct that is a piece of this, that it covers kids up to age 26, and the pre-existing condition is already in effect for children. That can't be held against someone for coverage.
Okay.
Yeah. So we said there are 50 million Americans uninsured. The number would be 51 million if we didn't have these kids between age finishing college and 26 on there. And that's not going to be taken away because people really like it and it's working, and it doesn't cost the insurance companies anything. Those are healthy people, so they're doing a good job of covering them. if the insurance mandate is thrown out, I don't see how the rest of it can work. If the insurance mandate, the mandate that everybody buy insurance is thrown out, and the insurance companies have to cover everybody, as I said, I don't see how those two can go together. Personally, I don't think that can work. The way it goes together is they have to raise premiums on everybody else, and they'd be absolutely right to do that because their costs are going to go up. Here's my fear, is the Supreme Court throws out the individual mandate. It could happen. And then President Obama says, well, that's okay. 85% of my bill is still in place. Well, for the moment, it would be. But I think it would be in a pretty precarious place if that happened. So I think it's a near fatal blow if that is overrun. What do you think?
Yeah, just to get back on your team, I'm going to agree with that and weigh in with respect to coverage of kids. They can stay on the parents' policy until they're 26, but the law also required that insurance companies accept all children, from the very beginning, even before it required that all children have coverage. And insurance companies immediately said, wait, that we don't have the paired deal that we need to make this work. You can't make us cover, sick kids if you don't make the healthy ones also get coverage. So they just stopped selling coverage for kids. They didn't stop selling it for families, but they said, child-only policies, we can't make that work. The economics are just not there, and so they just pulled out of the market, which is sort of an early sort of warning sign that if you take the mandate away, the rest of the structure will crumble.
Okay. All right. Back here.
Sue Jazarek from Greensboro. One issue that we haven't talked about, as I followed the development of this bill, was personally really disappointed. It seems like everything that's in it was based on either a financial or a political decision and not the moral issue, which I think is that in our country, as most countries, every person should be entitled to health care. That's a basic human right. Do any of you see any way that our country's going to get beyond terming health care in terms of politics and finances? That's all we talk about. And that everybody should have a right to this. Do you see a future for that in our country or not? Come on, optimist.
Not everybody at once.
I'll answer that. I think that's the winning argument. I think the way we're going to get to universal coverage is the moral argument, is imploring Americans to do the right thing, to care for the least of our brethren, to see to it that all our neighbors can see a doctor when they're sick. Most Americans agree with that now. And I was quite critical of the proponents of the Affordable Care Act because they focused so much on insurance company reimbursement rates on money and didn't really get to the moral issue. Right at the end, February and March of 2010, President Obama went to every state and met with families of people who'd lost a mother or father because she didn't have insurance. Finally, he got to that, but he should have done it all the way. And I think the way we're going to get to universal coverage is through that argument. I'll just tell you something. I wrote this book, and the way you sell a book in America is you go on talk shows, radio and TV talk shows, and a lot of them are run by what you might call shouting conservatives, And I went on a radio show run by one of these loud conservatives, Mike Rosen, nice guy. I've done a lot of my books on his show. And I walk into the studio. He's such a nice fella. He says, hey, Tom, how you doing? How are Peggy and the kids? Hey, congrats. The book's doing great. Congratulations. Really good news. Right? And then the red light comes on. And he says, Mr. Reid, you left-wing wingnut. How could you? He totally gets into character, And conservative radio has conservative audience. And here's what he said to me. His argument to me was, look, 85% of the people in America are satisfied with their health care arrangements. So why do you want to mess everything up in the $1 trillion bill for the 15%, says he. Well, I don't buy the premise, but I didn't have a good answer to that. And about 10 minutes later, this is conservative radio. One of his callers calls up, probably a pretty conservative guy. And here's what he says. He says, Mike, I heard that question. He says, 85% of the people in Montgomery, Alabama could ride on the front of the bus. So why did we mess everything up for the 15%? if you go down to the old Woolworths in Greensboro, you can see the same message. Eventually, Americans will do the right thing. We need a leader to take us there. That's what happened in every other country. A leader came along and said, doggone it, we're a rich country. We have a moral obligation to do this. And I'm with you, ma'am. I think that's how we're going to win this argument.
We have about 10 minutes left, so I do not want anybody to leave with a question that they just wish they had asked if they had gone to the microphone. Yes, sir.
Hey, my name's Ray. I'm from Greensboro. I've been in healthcare, either in purchasing from a research side or materials management, capital equipment, and then also sales. My concern would be, I know, the technology's changed so drastically from a patient care standpoint. If we limit research dollars, we don't get the products that we need to maybe get in front of some of these patient-centered outcomes that we need on the front end. And that's my fear with some of this going down the line, is how does the federal government suppose and connect the dots in that respect? Because I know the technology's quite a bit different than it was 30 years ago. And definitely we want to be in front of that instead of behind it and make the outcomes better. And again, I don't know how we connect the dots there and how any of you might address that.
Who wants to take that one?
Well, I'll get the ball rolling, and then I'd like to hear from the folks in the clinical trenches. There's a huge investment in information technology and getting computers to work better, to avoid all this unnecessary paperwork, and to really bring the information sort of usefully to the point of treatment or what have you. How's that going, by the way?
We're in the midst of implementing an electronic health record, and we haven't run Screaming from the Building yet, so that's pretty good. And that is part of it. There is incentive money for folks to do that. I think that will make a huge difference in being able to be sure to make less errors, to be able to communicate among primary care and specialty and hospital. So I think, and the state is moving forward on their health information exchange. So I do think that's something that's really supported federally for folks to be able to do that. But I agree, that's something that needs to be there, and that's something that Mr. Reid mentions in his book in terms of other countries that have, Jiffy Lube can do this. So we should be able to do it in healthcare. They know when you need to come in. We should be doing a better job here.
Yeah, I haven't answered this. I disagree with you. I don't think that we have to pay through the nose for health care to get good research. I don't accept that argument. The United States is a world leader in healthcare innovation. There's no question. We have world-class research. We're making breakthroughs every day that save lives. But you know what? Other countries with much lower cost bases are also doing brilliant work in innovation. Has anybody here seen your unborn baby through an ultrasound? That's Swedish technology. Anybody who's got an artificial joint, that's French technology. If you're walking around an artificial hip or knee, the French invented joint replacement. Two of the three biggest selling drugs in America, that would be Crestor and Viagra. Viagra was invented in Britain. Crestor is licensed from a Japanese company. So we do great at medical research, but other countries with much lower cost structures are also doing world-class innovation. So when people say to you, oh man, we got to pay more to get the research, I reject that argument.
Okay. Yeah.
I'm Alice Franks. I live here in Greensboro. This is slightly different, but just going back to the Supreme Court and the notion of doing the right thing, I have some concerns about appearances of conflict of interest of some of the justices who will be deciding whether the right thing is to recuse themselves or not from hearing this case, and I wonder if you have any thoughts about that.
That's you.
You said justices plural.
Yeah.
All right.
Yes, Scalia and Thomas had dinner
with yes. Okay.
Some folks the night before they voted to hear the case.
Yeah. So Justice Elena Kagan, who was in the Justice Department and at the time that the law was being formulated and all, was in a position to have possibly considered
its constitutionality or not. And so there's sort of countercharges that maybe she should recuse herself as well. So I think this sort of signifies the importance of the case. I mean, there's, just such heightened scrutiny of the stakes, of not just for health care, but actually for constitutional law and for the whole structure of our federal government. I don't think any of these justices are going to recuse themselves. The Supreme Court's rather special in this way, in part because there is no higher court, right? And so do you want to go in, with... so I'm not defending it. I'm just saying they think about the institution as a whole, and that there's just certain cases that just kind of have to be decided, and the facts typically have to be a lot more glaring than this to sort of really create a scandal, and so I don't expect to see any recusals.
Okay, and finally.
This has been a wonderful panel, and I appreciate the chance to witness it. My name's Dick Rosen. I'm from Greensboro, and I'm sort of ashamed to have a question about cost because obviously the moral values are much more important. But the states are about broke, and you're saying 16 million people are going to be added to the Medicaid rolls, and part of that's going to have to fall on the states unless the mix of dollars is changed, with more coming from the federal government. And I wonder, what is the possibility that this is going to fail simply because the states can't be ponying up that much more for 16 million new Medicaid patients?
Okay.
Well, that's a great question, and the answer to it is they foresaw that. The states already foresaw this when it was proposed. So I think it's the first 5 years, the federal government's supposed to pay the cost of the expansion of Medicaid for 5 years, and President Obama says he hopes that the states will continue to fund it afterwards. But it's a bigger issue than that. States don't have money for Medicaid. We're cutting it pretty sharply in my state of Colorado. And look, have you heard this expression, programs for the poor or poor programs? It's true. They tend to be underfunded, and Medicaid is one of them. If you had asked me to expand health care in America, I wouldn't have done it by expanding Medicaid, because those aren't, I think in North Carolina it's a pretty good program, right?
And this is where I would disagree with you, because Medicaid has been proven to be a very cost-effective program in terms of how much it costs to provide care and the outcomes of that care. And through programs where there's case management support, like the program that Dr. Earls works with, they're seeing even greater outcomes and even greater cost savings. And one of the things that I would ask the states is, so what happens if you don't? And I would even ask those opponents of health reform, so what happens if you don't do it? Can you just sweep health care under the rug? Will it just go away? Will the people just go away? No, they won't. So what happens? Where do they go? If you're sick, where do you go? You go to the emergency room. What do you think costs less? Go into, a public health department, a federally qualified health center, or the emergency room? That's an easy one. They've done the math on that. And there's a huge cost savings to have systems in place, prevention, early intervention, primary care, versus waiting for somebody to have that heart attack and showing up at the emergency room, or that mom, 8 centimeters dilated, waiting to have a baby, and she hasn't had any prenatal care. I mean, that's that old Jiffy Lube ad. You can pay me now or you can pay me later. So I think people want to do the pay me later and just go away. It's not going away. I think the difference between what we did a couple of years ago in health reform and what took place during the Clinton era, in the early 90s was, I think that the status quo was still manageable back in the early 90s, that doing nothing was still a realistic option. Doing nothing now is not a realistic option. Why did GM and Ford and Chrysler get into some real serious financial difficulties and need to be bailed out? It wasn't because they were building bad cars. I mean, they weren't great, but they weren't bad cars. Healthcare costs skyrocketed. That was why. And so doing nothing is not an option. States are going to have to pony up their share, and Medicaid is the best deal that they can get going right now.
Well, just a comment on Medicaid
Sure.
here in North Carolina. I mean, people, if you're not familiar, North Carolina is a model of Medicaid that other states are coming to see. So in North Carolina, our Medicaid program is called Community Care of North Carolina. So there are 14 community networks, and they are all, they started out with a major focus on primary care physicians, lots of family docs and pediatricians. They now include obstetricians who are part of a pregnancy medical home piece of all of this. There are networks that are working closely with their hospitals and health departments. So I had the great privilege a few years ago of going with our DHHS Secretary Alan Dobson to Washington, D.C., where we got the ASH Award for Innovative Government Programs. And the North Carolina Medicaid system has saved this state over $100 million every year for the last 10 years. You don't see that in the papers. Right now, CCNC is really working hard to cut costs by offering a medical home model and getting folks into primary care and offering care management, care managers that are in the home, that are in the practices and helping folks. So it's quite amazing. We've had a recent analysis by an organization called TREO that looked at the work that CCNC has been doing for the aged, blind, and disabled population, mostly adults with complex medical conditions, but also children. And the estimate is that over the last few years of that program, we've saved the state $1.5 billion. So it's something to be proud of in North Carolina, and it's a way to manage this. And we are struggling with the idea of how many additional Medicaid patients will come on with the expansion of Medicaid, and how will the state manage that. But as Ben says, how are we not going to manage it? This is going to bring on, for what we're hoping, a lot of the parents that we see who aren't eligible for any health care. Very important for the kids that I see that their parents also have good health and mental health. So it's something we've got to do, but we've shown in this state that we can really do that efficiently and improve outcomes. So that's my soapbox for what we're doing here, but I think it's very possible.
All right. Give her a round of applause. So as we bring our conversation to a close, what I would like each of our panelists to do, two things. One, name one statement that is a total myth about this law that makes your head hurt every time you hear somebody say it. Just think about it. Because, I mean, we know there are lots of moving parts. It's a work in progress. There's some things that are going to be decided in March. So we know it's not a final law, obviously. But there's got to be something that you just hear that you just say, where are they getting that from?
Well, as I said, it's a government takeover of medicine is wrong. It would have worked better, frankly, if there were a little more government involvement. Look, it's fine. The private sector can do a very good job of providing health care and paying for health care, but under this bill, most Americans under 65 are going to go to private doctors and private hospitals and pay for it with private insurance. It's not a government takeover of medicine. That one kind of bugs me.
Okay. Mark?
So I think it's not a statement, but a factoid that bugs me. In terms of the polling, I understand that people are divided on this law, deeply divided, feelings are strong, but as you start to look at the breakdowns, one poll really caught my attention, which is that folks who have a pre-existing condition, a chronic illness or something like that, have less support for this law than the average American. And that just means that this sort of eye on the prize, this key point has not gotten through because they have the most to benefit. It's those folks who should feel, I can't wait until January 1st, 2014, when now I can change jobs or dump this spouse or move to a different state. And not have to worry about my, inflamed hemorrhoids or whatever it's going to keep me from getting, insurance. And so failing to understand this sort of one core sort of key victory, it just bugs me.
The one that bugs me is the government's going to make me buy health insurance. Okay. And I use a corollary of the great state to the south of us, South Carolina, where you can ride a motorcycle without a helmet, okay? So you ride that motorcycle without a helmet, you hit a bump, you fall, you hit your head, and now you're quadriplegic, but you don't have health insurance. So who takes care of you? Do we just put you on the curb and let you die? No. Someone takes care of you, and someone has to pay for it. So we all have individual responsibilities in this world. And for someone to say, well, the government can't make me do something, you've got to balance rights and responsibilities. And this is just a matter of keeping our society, which is what we are. And a society, as the young lady mentioned, should be a morally based society, because there are a lot of people that wear that one on their shoulder too, should really put their priorities in order and recognize that this is how we're going to have to go forward as a nation, to be responsible for ourselves and for one another.
Marian.
Well, I guess the one that I've heard the most is that it's going to be socialized medicine, and we're going to have waiting lists like they do in Canada. So as one of my Canadian Pediatric Society colleagues pointed out when I was there a few years ago, 49 million is a hell of a permanent waiting list.
All right, so let's just go kind of around the horn and, just give people a takeaway and a closing comment. Anything that you choose to do. I think a lot of people have enjoyed the evening, but some just might wonder now, what do we do? Do we just sit back and wait for this to go through the process, or is there a more active approach? So you can either answer that or just hit a point that you always like to leave people with. Ben, are you ready?
Yeah, I would just say that the status quo is not sustainable. And if you don't like what's been put in the law, what's an option? And doing nothing is not an option.
All right. Mark?
Okay.
Well, Denise told me not to be political, but she can't turn off my mic now.
You can have mine.
I was just going for information.
So here's the problem. Okay, so November. All right, and so if we put into place an administration that doesn't believe in this law, but a Congress that isn't able to repeal it, what do we have? America, make up your mind. Do you want it or not?
All right, thank you. Mary?
Okay, well, taking it from the perspective of a primary care physician as a pediatrician, I would really like to be able to see a child and their family and not have to worry about whether they can pay, to be able to refer them or write a prescription and not have to worry about whether they have the transportation to get there, whether they're going to be able to pay for this for their child. I'd really just like to be able to take care of kids and families.
And I know.
Yeah, this is what all doctors say. I just want to treat my patients and provide health care for people, and the system is not letting me do it. My position for you is a rich, equitable, decent democracy ought to provide health care for everybody. We should do it. Because all the other countries like us do it, I know that we could do it. We should and we could. In fact, I would love to have you go out and buy my book, but if you don't have time, that's fine, because I can reduce the whole book to a bumper sticker. Are you ready? If France can do it, the United States can do it.
And with that, the Greensboro Public Library would like for me to remind you that this issue will continue to be explored, and they're doing it through book discussions. So all of that information is in your brochure. Please check it out, and please participate and remain engaged. Also in your brochure, you will see that WFDD's community conversation on the high school dropout rate continues. This one is going to be held December 1st at Winston-Salem State University. We do hope you'll attend. We hope you'll stay tuned to 88.5 WFDD and or WFDD.org. And in the meantime, will you please join me in thanking Mr. T.R. Reid. Dr. Marian Earls. Mr. Mark Hall. And Mr. Ben Money. And thank you all for coming. You've been a fantastic audience. We appreciate you. Have a good night.
I'll meet you around the corner.